Hello, everyone. I'm Dr. Marty Ross, and tonight is another Conversations with Marty Ross MD. Glad to be here with you. I know I've had to take a couple weeks off here, so I'm sure there's some pent-up questions, and I look forward to answering those for you. For those of you that tried to attend last week, I must apologize. I had, many of you may know, I have a couple Basenjis, and one of them had a procedure done on his teeth that went longer than I anticipated, so I wasn't able to make it in time. But we're all put back together well here. I'm actually joined tonight. Halo is laying in a chair right over here, and Thor is wandering the house somewhere. So we may see him pop in and out here later tonight. For those of you that are coming back again, I'm glad to see you here. I see many familiar names on my message board. I'm glad to see that you keep getting value out of these. For those of you that are new, welcome. I'm glad to see new people here. The way you participate, there's actually a couple ways to do it. Number one, you can write a question to me. It can be very bold if you want to. The way you do that is there is a chat box down at the bottom of the screen on the right-hand side, and you write your question to me there. The only thing I ask is that they're shorter questions. I can't deal with the whole history of your illness in this kind of forum, if you know what I mean. And also the other thing that I ask is do not click your enter key to create paragraphs. When you click the enter key, it actually sends a whole question, the whole complete question to me. And so if you try using the enter key to make a number of paragraphs, what you're going to find is that I'm going to have a hard time following the various parts because it's going to come to me in multiple parts, basically. The other way you can participate is listen to the questions. If you're in the live version of the webinar, you're going to be able to actually see those questions show up at the bottom of your screen. They actually post in the live version. However, they don't pick up in the recording. So I will also read the questions out loud so you can track what's going on with those. Tonight is the beginning of 4 weekly webinars that I'm going to be doing. So tonight and the next 3 weeks. Tomorrow morning, you will get an email from me announcing that the recording of the webinar is ready. So yes, I am creating a recording as usual. And in that email, there'll be links that you can sign up for the next webinar. And actually, you can sign up for all of them at the same time. You just need, when you go to the sign up page, you have to click which webinar you want to sign up for. So I'm going to be with you for 4 weeks in a row. All right. And so let's... I think that covers all the groundwork here. Let's go ahead and get started here. Hello, Gail. Let's see. Hi, Dr. Ross. I take 5 milligrams of LDN. That's low dose naltrexone, everyone. Recently, my cytokine levels with Quest have come down. Some still elevated, though, but specifically my interferon gamma, which was normal before, is now a 7.9, which is high. What does interferon gamma do? 2, I have HSV-2, herpes simplex virus, everyone, type 2, and rarely get outbreaks, but they are recurring a lot lately, which is upsetting. Could LDN 5 milligrams suppress my immune system, making it harder to keep HSV-2 and other dormant infections in check? 3, I take HRT, which is a hormone therapy, estrogen replacement therapy, probably progesterone too, the way you wrote that. Can Prometrium increase HSV-2 outbreaks? When I had period outbreaks, were often before my period when I think progesterone is highest, so was wondering. And 4, my chlamydia pneumonia IgM is positive, and I have been congested and feeling sick. Can Sida, acuta, and Houttuynia treat chlamydia pneumonia? All right. So that's a lot of questions there. I'm not going to be able to answer all of them. I will try my best, though. In terms of interferon gamma and the effect of LDN and what specifically interferon gamma does, I don't know. There are varieties of cytokines, and this is one that I don't know specifically off the top of my head what their direct effect is. So everyone, cytokines are a group of chemicals that are made by white blood cells when they see infections or they see toxins in you. And what they're supposed to do is turn the immune system on to deal with that problem. In certain conditions, they can be made in excess when the immune system doesn't do a good job, or in the case of autoimmune illness, if it gets turned on and keeps making these excess cytokines. Cytokines in general, if they're in excess, give you what we call Lyme symptoms. So they make it so you can't think, they disturb your sleep, they make you hurt all over, they interfere with how your hormonal systems function, they give you fatigue, they give you body pains, they give you neurologic dysfunction. And there's a variety of them, of which the interferon gamma is one. So I'm not going to be able to specifically answer your question on that one. In terms of HSV and LDN, I have not seen any of my patients. So HSV, everyone, would be HSV1. I always botch these up. There's two types of HSV. There's HSV1 and 2. One is supposed to be more cold sores around your mouth. The other one is supposed to give you vaginal or penile herpes outbreaks. And frankly, even though we designate one of those as being more oral and one of those as being more genital, you can get them either place, actually. So I just not remember on the top of my head which one is supposed to be more genital and which one is supposed to be more oral, because literally they can do both. Okay. Anyhow, I haven't seen in my practice in using low-dose naltrexone that any of my patients with either cold sore history or genital herpes history have a worsening in terms of outbreaks. One way to see would be stop your LDN. Do that with the advice of your physician, no, but stop it and see, does your HSV get better? There's many things that are common in terms of side effects and effects of different drugs and herbs, and there are those things that are less common. And one of the statements I have is that anything can happen to anyone with anything. Meaning, even though I haven't seen LDN causes, and I wouldn't call it a common side effect of LDN to result in HSV outbreaks, that doesn't mean it's not a side effect in you. All right. And the only way to find out if something is a specific side effect in you is to stop it, see if it goes away, reintroduce it again, and see if things happen in a bad way for you again. Now, again, you should talk to your physician about it. I'm not your prescriber, and I don't know all of your healthcare issues. Okay. All right. Let's see. Number 3. Where is your third part here? Hormone replacement therapy. Can Prometrium increase HSV-2 outbreaks? Again, I haven't seen that happen. I'm not aware that it would cause that to happen. Okay. And then number 4, chlamydia pneumonia IgM is positive, and I have been congested and feeling sick. All right. So chlamydia pneumonia, everyone, there are a number of types of chlamydia. One of those is something that can be sexually transmitted chlamydia. And then there is a respiratory chlamydia, which is not sexually transmitted, called chlamydia pneumoniae. Chlamydia pneumonia can be both acute and chronic. And in acute phase, it actually can give respiratory syndromes, basically. It can give bronchitis, it can give coughing, it can even give pneumonias, may even give some congestion. Okay, that's respiratory. The fact that you have an IgM antibody that's positive makes me wonder if this is more of an acute rather than chronic. Everyone, there's 2 families of antibodies that we tend to follow in infections. There's a family called IgM, and there's a family called IgG. IgM antibodies are what your immune system first makes to an infection. And then often by around 6 weeks to 3 months in most infections, those IgMs go away and they get replaced by IgG. Once you make IgG antibodies, they are the memory of the immune system. And you'll keep making them even after an infection is gone. So we can't really tell by just looking at an IgG whether an infection is in you and active. Chlamydia pneumonia happens to be one of those infections that can live in us chronically and not cause any problems. It can live inside of our cells, and our immune system does a good job keeping it under control. So we cohabitate with it. But in an acute setting, it can give you some of these symptoms like you're suggesting. If we look at things that might work about it herbally, Sida, acuta, and Houttuynia, which are 2 herbs that we use for a Bartonella treatment, can also be effective, have some effect against chlamydia pneumoniae. And if I were to use them for that purpose, I would probably dose them up at 30 drops of each twice a day. And that would be using a tincture that is a 1-to-5 extraction. And what I mean by that is when liquid tinctures of herbs are made, basically you take a bunch of plant and you stick it in alcohol and you let it sit there for weeks. And during that, while it's sitting there, the alcohol pulls out the active chemicals. And a standard extraction that's usually done for most herbs is to do what's known as a 1-to-5, which is 1 part plant to 5 parts of alcohol. Okay, that's how we do most of those. Okay, all right. Gail, thanks for that question. Sorry I don't have all the answers for you, but I hope I gave you some things to think about. Okay. And good luck to you. Hello, Lynn. Let's see how Dr. Ross. Last time you said it was fine to take Boswellia with Mariva 500. Do you have a brand type of Boswellia that you like? And what dosage do you recommend? Is it okay to also take PEA with those other 2 supplements? Also, my recommendations, any recommendations of digestive enzymes? Finally, do you have any opinions on Cyrex, a lymphocyte map test for evaluating Th1, Th2 dominance? All right, so let me try to answer some of these as best as I can. So I don't use Boswellia in my practice, so I can't tell you the actual dosing of it or a good source for it. I just don't have working knowledge of it other than knowing it is an herb that can be anti-inflammatory. So I'm afraid I'm not going to be able to help you with that. What I like using as my anti-inflammatory herbs in Lyme disease management is a curcumin. Quercetin is another one that I like using. Black tea extract can be something that can be helpful as well too. Those are the kind of things that I like to use. I haven't tried Boswellia to know if it would work or not, to be honest with you. Okay. And then in terms of using PEA, which is another supplement along with Boswellia, along with Mariva 500, I see no problems with that. In terms of digestive enzymes, if I've got somebody that is having pancreatic dysfunction, so pancreas, everyone, is an organ that sits on the, left-hand side of the abdomen, and it connects through a duct, the pancreatic duct, into the bile duct, and through that it releases its chemicals into the intestines. So the pancreas does a number of things. No wonder it's a hormone organ, so it makes insulin. Okay, but the other thing it does is it makes enzymes that help break down our food. So it makes proteases, which break down protein, lipases that break down fat. It makes enzymes that break down sugar. So it's the digestive enzyme organ, if you will. Now, it is possible that either due to primary dysfunction of the pancreas, it just stops making adequate digestive enzymes, or as a result of having a makeup of unhealthy bacteria in the intestines, if you get dysbiosis of the intestines, that can lead to incorrect signaling by the intestinal lining that would tell the pancreas to actually make these enzymes. And so if you're somebody that has a lot of bloating and gassiness, or loose stools, frequent loose stools, it is reasonable to think, could you have pancreatic enzyme dysfunction? The way that I like to look for that as a possibility is to do a comprehensive GI study using a lab like Genova Diagnostics. Great Plains has one. The GI map is another one. And you can look at, in those studies, they look at some of the enzymes that are made by the pancreas, and you can see, are you low? The other thing that they do is they look at something called beta-glucuronidase, and if that's elevated, that suggests that you have intestinal dysfunction, which could, bacteria dysfunction, which could lead to pancreatic dysfunction as well too. So if I do see the low pancreatic enzymes in that study, or if I see that somebody is having problems with loose stools and gassiness, I might try pancreatic enzymes. And the product I like for that is a product made by Integrative Therapeutics. It's called Similase. And I usually have people start at 2 pills, working all the way up to 4 pills if needed before meals. You can take like about 10, 15 minutes before your meal. And if it makes a difference, then you know that's a reasonable way to go. And then in terms of Cyrex lymphocyte map tests for evaluating Th1 and Th2 dominance, I've been looking into the Th1, Th2 dominance, and there's theories that with Th1 dominance, you might see more certain cytokines than you would see with Th2 dominance. But the reality is there is no valid way to really tell whether you have Th1 or Th2 dominance. There's a lot of crossover in the way that the different cytokines work. And so I haven't, I'm skeptical of any lab that has testing that they think is valid to evaluate Th1 and Th2 dominance. Yeah, that's where I'll leave that one. Okay. All right. Thanks, Lynn. Good luck to you. Hello, let's see, is hydroxychloroquine ill-advised for those with any form of vision issues? What if the vision issues have been caused by tick-borne infections and hydroxychloroquine is part of the treatment? On a different note, if someone has low serum ferritin, which dietary or supplemental recommendations would you suggest? Thank you. And I hope Thor is well. Yeah, Thor's doing fine. The poor kid, he had quite a bit of dental work done. Basically, Thor has a lot of separation anxiety. And unfortunately, even though I periodically will have to put him in a crate to protect my belongings when he gets in a real bad state. And I have a crate that is made for dogs with separation anxiety, and is made in a way to have it so that they won't injure their teeth. He still found a way to do it. So he cracked a number of teeth that way, unfortunately. And so they had to extract them. And so he's doing fine now. And I still have to figure out how to deal better with his separation anxiety. So that's another discussion altogether. Anyhow, hydroxychloroquine, everyone, is a medication also known as Plaquenil. And it was originally designed as an anti-malaria medicine, an antibiotic to treat malaria. Probably the number one prescribers of this medicine now in the world would be rheumatologists, because it also has anti-inflammatory effects that are helpful in people with rheumatoid arthritis and other types of inflammatory arthritis. In the world of Lyme disease, we actually use it for a couple different reasons. One, it can be anti-inflammatory. It can be helpful if people have a lot of joint pain and inflammation. The other thing that it's useful for in the world of Lyme is it helps intracellular antibiotics like your tetracyclines, minocycline, doxycycline, and your macrolides, which would be clarithromycin, also called Biaxin, and azithromycin, also called Zithromax. And probably even Rifampin, it may help work better too, but it changes the acid levels inside of what are known as vacuoles inside of your cells. And inside vacuoles is where Lyme likes to live. And if we can make those vacuoles less acidic, it makes it so that the antibiotics may work better. So one of the reasons we use it is to help those antibiotics work better. And then finally, there are some of my colleagues that will use it to treat what is known as the cyst, a form of Lyme, but I will tell you there's conflicting data. Now, there's some data that says that being on hydroxychloroquine may promote more cysts to grow. And so I tend not to use it as an anti-cyst agent. So many of you may be familiar, Lyme has different appearances or forms. One of the forms is a corkscrew looking thing called a spirochete. There's another form of the germ where it moves inside of cells. We call that the L form. And then finally, another form of the germ is a microscopic cyst form of the germ. And so, again, some of my colleagues would use it to help with that. But I think there's better things to use. I like herbally. I like using grapefruit seed extract, for instance. The herbs otoba and cat's claw, which we can use to treat Lyme, also are good cyst agents as well, for instance. And then your azoles like tinidazole, metronidazole, fluconazole have anti-cyst properties as well too. So I tend to use other things than hydroxychloroquine. All right, so if I am going to use hydroxychloroquine to help my tetracyclines and my macrolides work better, or if I'm going to use it as an anti-inflammatory, the way I'm going to dose it is at 200 milligrams twice a day. At that dose, there is no problem with the eye. All right, so the problem with hydroxychloroquine at higher doses is it can lead to retinitis, or an inflammation of the back of the eyeball, the retina. And so I used to, when I had people on hydroxychloroquine before I understood that at low doses you don't have the problem, I was sending my patients off to the eye doctors every few months to have their eyeballs looked at to make sure they weren't getting retinitis. And the eye doctor started sending people back to me saying, you don't need to do it. It's if you do get above 200 milligrams twice a day, in that kind of situation, you should do your eye screenings. But below, so at 200 milligrams twice a day or lower, there isn't a problem with it. So anyhow, that would be my comment about the eyes. Okay. And then finally, in terms of low ferritin, everyone, is the storage form of iron in the body. And so if you have low ferritin, you need to increase your iron intake, basically. And you can do that either with red animal meats. You can do that with a lot of green leafy vegetables, or you can do it as a supplement. And what is useful as a supplement, there's various forms of iron. I like working with a product by Thorne called Ferrosorb, which has a very easily absorbed source of iron that tends not to constipate a person. Then I have patients with low ferritin. I might start them at 2 pills one time a day of that product. Okay. All right. Thanks for that question. Or I should say questions. Hello, Bill. It's hello, Dr. Ross. I was on BPC 157 for 3 months, and it helped the neuropathy in my feet, where I get a burning sensation in the middle of the night, and it keeps me awake. I stopped the BPC 157 2 weeks ago, and the neuropathy is back. Do you think I should go back on for another 3 months, or is BPC 157 medication that has to be taken all the time? Also, is it okay to take low-dose naltrexone and BPC 157 and curcumin and quercetin? Many thanks, and wish you the best on the next phase of your career. Thank you. I appreciate that, Bill. So there is not a length of time that you have to limit yourself to taking the peptide called BPC 157. Just to say that, okay? Usually I tell people when I use it to do tissue repair, like nerve repair or muscle and tendon repair or brain repair, I'm going to have people try it for a minimum of 3 months to see if it works. If it is working, I usually advise even using it for another few months to lock in those changes. So in this kind of a situation, I usually would have my patients go ahead, go back on it, use it for another 3 months, and then try to come off of it again. There's a point at which it should do enough repair that you don't need to stay on it, okay? But 3 months probably wasn't enough here for you, okay? So everyone, there's a group of treatments that are called peptides that many of us are starting to use that treat Lyme disease. And to clarify, what a peptide is, peptides are made up of a building blocks called amino acids. Well, many of you may know proteins are made up of amino acids. So what's the difference between a protein and a peptide? Well, one of the big differences is how we classify them. We say that if there are 40 or less amino acids together, we call that a peptide. If there's over 40, we call that a protein. And that's an artificial designation through the Food and Drug Administration. And they had to decide whether they were going to regulate peptides as drugs or not as drugs. And they decided that they won't regulate it as drugs in terms of calling it a drug if it's under 40 amino acids. Now, it gets a little tricky for injectable peptides. The Food and Drug Administration, even though they don't call them a drug, they have rules governing what compounding pharmacies are able to make when they make something. Okay, so in terms of the compounding pharmacies, they can only use compound things that are proven to be safe and also have some science shown that they are efficacious and are effective. And the FDA maintains a list of things that they say they allow compounding pharmacies to make. All right. Now, when it comes to peptides, it's a gray area because the FDA is allowing manufacturers to make compounding pharmacies for injection to make peptides while they evaluate the science around which ones are safe and which ones can be effective. And at some point, they're going to have to come up with a final list saying which ones can be made and not made. So at this point, medical boards like my medical board in Washington State, I refuse to do injectable peptides in Washington State because my medical board, I know from when I had my dealings with them, they would scream if I was using injectable peptides because they would say it's not FDA approved. It's not on an approved list. And again, because the FDA hasn't come up with that approved list that they allow compounding pharmacies to make. Now, I know a number of my colleagues do injectable peptides, and I think, we all have to decide what risks we're willing to take. But I do think it's quite a risk, and it's one I choose not to take with my medical board. There are a number of peptides that are available orally, though, okay? And there's a company called Integrative Therapeutics that is making oral peptides. I carry all of their products whenever they have them available. They haven't had the greatest track record in terms of their availability, but I do carry them. We estimate now that there probably are at least 100 peptides that are made naturally in the body. And the one called BPC-157 is made by the stomach lining to help intestinal function and do intestinal repair. But it's been observed for a long time that athletes find it useful for athletic injuries. And so it can help with any kind of tissue injury, including neurologic injury. It may help your cell energy factors called mitochondria work better. It may create better balance in the inflammatory chemicals made as part of Th1 and Th2 inflammation. And also it has some weak ability to regulate your mast cells or your allergy cells in the body as well too. All right. So if I've got somebody that I'm trying to do tissue repair work, I like using BPC-157. I've got somebody that I've done lots of antibiotics and they still have symptoms that are just not getting better. You have to raise the question, do you have injury to those tissues created by the germs? And so in those situations, I may stop antibiotics. Like I've had patients that I've used antibiotics for 2-3 years and we get to a point they're just not getting better, but they still have symptoms. Those are the places I might add in oral BPC-157. It comes as a 500 microgram pill, and I have people take one pill twice a day to start with, okay? There's other peptides too, and what I'll do here in a minute, I'll do a screen share and show you the article. You can look at the other oral peptide possibilities. I have an article that describes when you might want to use one or more kinds of peptide products, okay? So I'll show that to you here in a minute. All right, in terms of the other part of your question, can you use low-dose naltrexone and BPC-157 and curcumin and quercetin together? And the answer is yes, you can, okay? So BPC-157, in terms of other things it does, is it can regulate cytokines and Th1, Th2 release of cytokines. Curcumin gets directly inside white blood cells and blocks cytokine production. Quercetin gets directly inside white blood cells and blocks cytokine production, but in a different mechanism than what curcumin does. Low-dose naltrexone is a narcotic blocker. Our bodies make a group of chemicals called endorphins, which are our natural narcotic systems, but those endorphins also regulate the immune system. And if you provide a short-term blockade with low doses of naltrexone, that causes a number of things to happen. One of those is it helps to upregulate a type of cell called a T regulatory cell. And T regulatory cells decide how much Th1 cells they're going to allow and how much Th2 cells are going to allow, and therefore how much inflammation they're going to allow, basically. So LDN can help with T regulatory levels that then can regulate Th1, Th2 inflammation to get cytokine levels under control that way. So to sum it up, basically, BPC 157 is a different mechanism that it regulates cytokines than what curcumin does, than what quercetin does, and then what LDN does, low-dose naltrexone. And therefore, you can use them all together. There's no problem doing that. Okay? All right. All right. So let me do a quick screen share. Bill, good luck to you. Thanks for that question. All right. So let's see here. All right. Okay. So this is my Lyme disease information site, Treat Lyme by Marty Ross MD. You can look under my online Lyme guide. And if you were to look under the immune system, I think that's where I put my peptides article. If not, we'll type peptides in and find it that way. Well, looks like I got to come back here and reorganize. There it is. Key oral peptides. All right. So my article is called Key Oral Peptide Strategies to Repair and Restore in Lyme and Mold Toxicity. And in here, I describe what peptides are. I talk about the variety of them that you can find orally, BPC 157. I talked about cerebrolysin is one that can help with traumatic brain injury and infectious brain injury and may help with thinking. Thymosin beta 4 active fragment is something made by the thymus gland that can help regulate cytokine levels. KPV is another one, peptide that can help stabilize. The main thing that it does is help stabilize mast cell activation. And so that can be useful for that. Thymosin alpha 1 is something that can help with T regulatory levels, to help increase T regulatory levels and balance the amount of Th1 and Th2 inflammation, etc. So anyhow, you can look here. I go through under what situations would you use them and how would you build treatment together using these different things, okay? In terms of where do you get them? So the peptides, the oral peptides, are sold by a company called Integrated Peptides, and you can find their products here. I will let you know that I'm still not sure about this company. I think they make good quality products. However, they've had a hard time regulating their production levels. And so we periodically run out of their stuff. They have been out of the BPC 157 capsules. It is now back in stock, and we'll be ready to start shipping those on Friday. Well, Friday or Monday. Anyhow, you can start placing orders again with me. I've got those back in stock. The other ones that they are running out of, I still have the TB4 frag, but we'll be out here soon, and they're probably about 2 weeks away from having that. The Thymogen alpha 1, which can help regulate upregulate Tregs and balance out Th1, Th2 inflammation. That one may be about 4 weeks or more down the road until they have that one back again. So anyhow, those are this is a place that you can get them if you want to get them here. Okay. All right. All right. Let's see. Hello, Cheryl. Let's see here. I was diagnosed with Lyme disease using a Western blot test more than 30 years ago. I also have rheumatoid arthritis confirmed with x-rays and blood work. I have used many products to address both maladies. None have been completely successful, though I've had periods of relative remission in which pain is as little as 2 out of 10. Following a stressful 6 months right before the pandemic, during which I experienced one of those relatively good periods, I used Microbe Formulas protocol for parasites. I dumped a lot of ropeworm that summer, especially after coffee enemas at full moon. The pain I experienced, easily 8 out of 10, was not in my joints, but in the connective tissues. It felt like strands of my hands and feet were being gathered into a too tight ponytail. Cautiously enough, the pain would subside to 2 out of 10. Within 15 minutes of finishing the enema, this has been going on for more than 2 years. At Christmas time, the past year, I passed a segmented worm for it. Cheryl, let me see if there is another part. This is getting to be a long question, so hold on here a minute. I don't see a question to this. Unfortunately, you wrote a lot of things here, but I don't see what the question is, and I'm not finding where the question is here as well, too, unfortunately. So I'm gonna have to let that one go. I apologize for that. Hello, Mary. Hi, Dr. Ross. Thanks again for doing this webinar for us. I hope Thor is doing well now. I have read that rifampin is bactericidal, some publications, and bacteriostatic in others. Which one is it? Thank you. Yeah, interesting question. So bactericidal means an antibiotic kills the germ outright. Bacteriostatic means it stops the growth of the germ, and basically the germ withers and dies. The immune system eventually gets rid of it that way, okay? So rifampin, if we look at studies about tuberculosis, which is what it was originally designed for, there's good evidence with that it's bactericidal. Depending on other germs like E. coli, it has been shown to be bacteriostatic. All right. And the truth is, I haven't seen the studies done on Lyme. There's no Lyme germ studies that say how it works. Trying to think, yeah, even with the studies I've seen, the Petri dish studies I've seen looking at rifampin for Bartonella, never described the mechanism by which it works, other than it does lower the Bartonella. Bartonella can be quite effective against it. The mechanism by which it works should be useful against cyst Lyme, although there's no studies that prove it actually works against cyst Lyme either. So regarding Lyme, I'm not sure the actual mechanism by which it works, whether it's bactericidal or bacteriostatic. I can't tell you for sure. All right. Thanks for the question, Mary. Hello, Irina. Let's see. Thank you, Dr. Ross. Your webinars are very detailed, very comprehensive, and truly helpful. Well, thank you. I hope they're giving up. Let's see here. Question number 1. 5 years ago, I had flu-like symptoms with severe sore throat and severe synovitis with multiple joint swelling and 8 out of 10 pain with the negative strep. Tests came positive for multiple pathogens, including Lyme, Bartonella, Babesia, EBV, CMV, etc. After multiple months of oral and IV antibiotics treatments, I'm 70% better, but still have joint swelling and pain that comes and goes, and I can't exercise. It causes bad flares. On Sporanax now, but have a hard time tolerating it, bad GI side effects. What do you think my ongoing residual symptoms might be related to mold, Lyme, Bartonella, etc.? How do I get back into my sports activities? Thank you so much. All right. So it's a hard question for me to give you the best answer, because what I would need to know a few things. Number one, I would need to know what you used over the last 7 months. And with what you use, would there be things that you use that would have been adequate to treat Bartonella and adequate to treat Lyme? And were they used long enough for the Bartonella? Now, the Lyme germ, in terms of how long do you need to treat Lyme, you treat Lyme for a long time. It's a very slow growing germ. An average treatment length is a year or more. And I say more, average of 2 years. All right. So the ongoing symptoms could suggest you just haven't treated the Lyme germ long enough. All right. Bartonella, the reason I pulled that one out is if you are on a Bartonella treatment that's working, or that is supposed to work against Bartonella, I should say, usually by 2 months of using that treatment, you should start seeing improvement in the Bartonella symptoms. And about 85% of the time, if you treat Bartonella for 6 months, you're done treating it. Okay. There's 15% of people, it does take a lot longer, but 85% of the time, people can get better. So you need to look at what your initial symptoms were before you started treating and figure out whether you might have Bartonella under control. So it is true, Bartonella can sometimes give joint pains, but the other common things that Bartonella give are, number one, pain in the soles of the feet. Sometimes people with Bartonella have air hunger. That can happen in Babesia too, but air hunger can be part of it. People with Bartonella often have ongoing anxiety that's just with you all the time. And as you treat, it tends to get better. They might have depression as well too, might have hallucinations, for instance, too. People with Bartonella tend to have a lot of neurologic symptoms, of which the big one is severe thinking difficulties. And kind of a clue that Bartonella could be there is the thinking difficulties in Bartonella are so severe that they tend to be relatively worse than the energy impairments that people have. So if you've got somebody that has their energy levels are 30% of normal, 50% of normal, and their thinking levels are only 30% of normal, you start wondering, could Bartonella be part of that picture as well too, okay? So anyhow, you look at some of those symptoms and you look and see, did they get better? And if a lot of them got better, that means you probably got your Bartonella in control. What you may be left with is just Lyme by itself, in which case you might want to still keep treating longer for Lyme. Okay. All right. And yeah, I mean, when people don't get well, you start looking at the possibility of mold toxicity. If you've got mold toxins trapped in you, they will trigger a inflammatory syndrome that can look just like Lyme and look just like Bartonella. So yeah, I mean, it's something to consider looking at. Okay. So anyhow, those are some thoughts for you. Okay. In terms of symptoms of Bartonella, if you want to see what that list looks like, let me just do a quick screen share here for you. All right, so in my online Lyme guide, you can take a look at the section called How to Diagnose and take a look at this article called How to Diagnose Bartonella and Chronic Lyme Disease. I list in here the symptoms that you use to diagnose Bartonella and that you could follow them to see, did they get better with your treatment? Okay, all right. All right. Good luck to you, Arena. Hi, Dave. Dr. Ross, I registered for the 315 webinar and I was not able to watch it. I never received the replay of it. Is there any way I can see this? Thanks, Dave. So Dave, unfortunately, I did not have that webinar. I actually wound up having that one. I gave notice a couple of days ahead of hand that I wasn't going to be able to do it. And then unfortunately, last week, I had literally a last minute cancellation of last week's webinar because of my dog, Thor. So anyhow, I'm glad you're here tonight. All right. Hello, Ricky. Yes, yeah, Dr. Ross. Thanks for answering my question. You're welcome. Which of the tick-borne illnesses cause eye floaters? Which one is most associated with floaters? Thank you. There's no science that has been done on this one, not that I'm aware of. I haven't seen any studies on this, but my experience suggests it's probably more the Lyme infection, Borrelia Lyme infection, rather than Bartonella, rather than Babesia, rather than Ehrlichia, rather than Anaplasma, rather than anything else. Okay. All right. Thanks for the question, Ricky. Good luck to you. Hello, Larry. Let's see. 37-year-old male, former South Texas geologist. Several years of presumed Lyme, untreated, with internist, derm. Actually, let me get my glasses out here. Let's see. 37-year-old male, former South Texas geologist, several years of presumed Lyme, untreated, with internist, derm, ENT, allergist, infectious disease, rheumatology workups to no avail. On disability with overwhelming fatigue, arthralgias, myalgias, peripheral neuropathy, digestive issues, cognitive impairment, psychological features of anxiety, depression, and panic attacks. Also has Morgellons, especially of head, neck, nasopharynx, physician documented filamentous dermatitis. Flare-ups are every few weeks. IGeneX comprehensive panel done, negative for Borrelia and all co-infections, although rickettsiosis of 40 under 40 is normal. The yeast screen per your book of 149. Lab is pending for syphilis treponema, but unlikely to be positive. Should I treat yeast and what to treat Morgellons with? Could lab be an error since Morgellon is usually associated with Borrelia? Should I start an antibiotic and which one? How would you start and proceed? All right. So, Larry, I'm wondering, you didn't identify yourself as a healthcare provider here, but given that detailed history, I wonder if you are. So let me give you some ideas here. So when we make a diagnosis of Lyme disease, there's four things that you consider. One, and you probably know this, but I'm just going to go through it for everyone here in the webinar as well too. So number one, you look at, is there a risk of getting the germ? And the greatest risk would be, do you do activities that might have put you in contact with ticks that carried Lyme? Okay, now, being a geologist, being outside, I would suggest you probably have been in areas with brush and everything. There's the possibility of having picked up Lyme from a tick. And yeah, in Texas, there is Lyme. It's not as great in the tick population here as it would be up in the Northeast, but it's here. I'm in Texas. I'm in Austin tonight, by the way. But there's the possibility, given the type of employment you have had, being a geologist, okay? So you've got a risk factor, all right, of getting it. Number two, all right, now regarding the risk factor of ticks, obviously the highest risk would be if you had a tick bite with a bullseye rash occurring in the Northeast, right? That's diagnostic of Lyme, just that. But you have to look at clues about people's employment to say, could they have gotten it? And the answer here is yes. All right. Number two, second thing you consider is, are there any physical exam findings? And the thing about physical exam findings is the majority of them are not specific for Lyme. But you did mention the Morgellons filaments that you're seeing, okay? I consider Morgellons to be a skin manifestation of Lyme, all right? And there, we're still trying to for sure understand exactly what Morgellons is, but the majority of people that have Morgellons have Lyme when you do testing. And I think it's a skin manifestation of Lyme disease that some people get, okay? So that means something to me right there. I think you have a Lyme condition that you've been able to see on exam, okay? All right. Number three, you look at, are there enough symptoms that suggest Lyme? And, all these symptoms you just listed here could be Lyme symptoms. So I would say yes there. And then the fourth thing we look at is there a supportive test? Now, you notice the way I said that. I said, is there a supportive test? And I said supportive, not diagnostic, okay? A test never diagnoses an illness. A test is just another clue we look at. And that clue could be right or wrong, all right? Meaning a negative test could be wrong. All right. So one thing we see when people have chronic Lyme that has been untreated or chronic Bartonella that has been untreated, often they will start with negative test, and after they start getting better, the test will become positive. And that happens about in 20% of people. And so if I have a situation like this, because I think he's got this person you're describing, there's risk of getting it, There's a Lyme-specific condition called Morgellons that this person has. There is enough symptoms that look like Lyme. It looks like a duck, walks like a duck, it's a duck. This looks like Lyme and possible Bartonella to me from the symptoms that you're talking about. Panic attacks may be part of Bartonella or could be part of Babesia. What I usually would do in a situation like this, as you've outlined here, is I would talk to my patient and say, look, I think you have Lyme and possible Bartonella. I don't have a test that proves that. But for the various reasons I just discussed with you, I think you got it. And I would say, I suggest that we start to treat and that we do a 6 to 9 month treatment using either herbal or prescription antibiotics. And we target Lyme infection and Bartonella, I think, in this case. And the reason I'm thinking Bartonella is the ongoing anxiety, neuropathy, digestive issues, severe cognitive impairment, psychologic features, et cetera. That to me says Bartonella. Okay, now, could Babesia be here? Maybe, but generally in my practice, what I follow the teachings of Burrascano when it comes to how you, Burrascano, everyone, is a physician that pioneered Lyme treatment in this country. And many of us were taught by him. One of the things he taught, based on his experience in his Long Island practice, is that if somebody had Lyme, Bartonella, and Babesia, it's best to go after the Bartonella before Babesia. If he did it the other way around, he thought, based on his experience, that it became more complicated to get rid of the Bartonella. Okay. So I usually will treat Lyme and Bartonella at the same time. All right. How could you do that? Two ways I might consider starting in something like this. All right. So first of all, I would probably use doxycycline. And the reason I would use doxycycline is it's effective against spirochete and intracellular Lyme. It also is something that can help with Bartonella, but it also picks up some co-infections that he could have that aren't showing up in testing, which would be Anaplasma and Ehrlichia. Doxy is your treatment of choice for those. It'll also pick up that Rickettsia as well too. All right. So if you use it for at least a month, you've covered the possibility of Rickettsia, Anaplasma, and Ehrlichia while you've got him on something to help with Lyme and with Bartonella. Okay. I would also combine it. These days I've been combining it more with fluconazole. All right. Now, why am I talking fluconazole here? Well, fluconazole could help yeast, and he's got that borderline score. But also fluconazole, the azoles have got some lab evidence that they can treat Bartonella, persister Bartonella, and growing Bartonella. All right. So that's based on Hopkins experiments from about 3 or 4 years ago, where they showed that clotrimazole, another azole, could be effective against Bartonella. They did not specifically test fluconazole. Over the last year, though, I've been using a lot of fluconazole in my practice for Bartonella, and I'm finding it very helpful. The other thing that, as an azole, that fluconazole could do is pick up cyst Lyme too. We know there's that flagyl, which is an azole, and tinidazole, which is an azole, can treat cyst Lyme, and therefore probably fluconazole does too. So one option is a doxy 100 milligrams twice a day with fluconazole 200 milligrams a day. That could be a full Lyme and Bartonella treatment. The other option would be to do a doxy and possibly rifampin, rifamycin. Rifampin is very effective against Bartonella, and then also probably picks up the cyst form of Bartonella as well too. All right. You might start him on that kind of a path for about a month or two, and then eventually to that, add in some liposomal cinnamon, clove, oregano capsules. The reason I use those is we use those to treat persister forms of Lyme and Bartonella. I wouldn't do it right away because it can give quite a Herx reaction. And I think you're going to be managing Herxing here just because of treating Lyme, possible Lyme and Bartonella. Okay. Now, as you know, as you start treating somebody, he may get worse at first. All right. And I would encourage you to take a look at my full treatment protocol, the Ross Lyme support protocol, where I talk about doing things to get sleep, lowering cytokines, controlling your Herxheimer reactions, supporting the intestines. For the yeast, not only do you want to use the fluconazole, you probably want to have them on some nice statin as well too. But take a look at that. You probably have looked at that, but take a look at that too. So anyway, that's what I would do in a situation like this. I've got a number of people that the testing just isn't positive right away. And often it will become positive about 6 months, 9 months down the road. But you tell them we're going to use antibiotics as an experiment to see if it's going to help you. And you get his agreement on that. I mean, if he's not willing to do that, then don't bother. But there's enough here that makes me wonder about Lyme and Bartonella. All right. Thanks for that question, Larry. And good luck to your patient. Hello, Lynn. Hope your dog is doing okay. Thor is. He's doing better. He's hiding out back. He's sleeping in my spare bedroom right now because Halo has taken over his normal space, sleeping beside me up here right now. So those are my two Basenjis. Thanks for asking. Hello, Heather. Hi, Dr. Ross. My wife has been struggling with Lyme and POTS for a few years now and seen multiple doctors and had multiple treatments with no improvement in symptoms so far. She's looking into another treatment with Disulfiram and wondering if you have experience with that or have recommendations for or against it. Okay, so boy, I gotta say, to answer this really well, I would need to know a lot more information. I will make a comment, but the reason is if she's still struggling, you have to wonder about the adequacy of what was tried. And so at a minimum, I would want to make sure that if her Lyme has been treated, that at the same time, she was put on an agent that dealt with spirochete and intracellular Lyme, something that dealt with cyst Lyme, and that she was also in something that would deal with persister form of Lyme. Okay. And so I review that in a number of spots on my online information site, but you might want to take a look at my Lyme disease antibiotic guide to make sure that that was done. All right. And if not, you still need to do that. Okay. Something else, if you've got somebody that's not getting well, that can lead to Lyme-like symptoms and POTS, which is paroxysmal orthostatic tachycardic syndrome, everyone. Basically, when people have POTS, they have an imbalance in the adrenaline, anti-adrenaline system of the body. And it results in people having a hard time keeping adequate blood pressure when they stand up, or periodically their heart will just go off and race on its own. There's a lot of skipping. The other thing to think about when people have POTS is sometimes babesia can be part of it too. And so, Heather, another thing to look at about adequacy of treatment is, but is babesia there? And was it dealt with adequately as well too? So symptoms that make you think of babesia would be drenching night sweats, air hunger, POTS symptoms, so skipping, racing of the heart, getting lightheaded easily on standing, headaches in the front of the head. And one other babesia type symptom that's an odd one that sometimes people get, is people with babesia can have frequent deja vu experiences, okay? So the starting point before you look at Disulfiram is to say, was there even adequate treatment done to begin with? Was there adequate treatment for all forms of the Lyme germ? So Lyme has different appearances. That's a spirochete. Lyme lives inside cells. That's called intracellular Lyme or L-form Lyme. And Lyme has a cyst form. In addition, Lyme has different growth states. There's growing and there's persisters. Okay, so you need to make sure there was coverage done for that. Liposomal cinnamon clove oregano is something I like doing for persisters. Disulfiram is something that might treat persisters as well too. Okay. Also, you want to make sure that all the conditions that look like Lyme that can trigger this were dealt with. So was babesia part of it, and was it dealt with? The other thing that can look a lot like this is if a person has mold toxicity and they get mold toxins trapped in them and they're not dealt with, then that can give a problem that looks like this. The way to see if a person has mold toxicity is to do testing of their urine for a urine mycotoxin test. The labs that I like to look at that do that are either real-time labs or Great Plains labs. I prefer real-time, but Great Plains lab does a urine test for that as well too. Okay, so you got to make sure you've covered all your bases first. All right. Now, disulfiram. So disulfiram is a drug that took the Lyme world by storm about 4 years ago now. I guess coming up on 4 years ago. And so disulfiram is a drug that is used to treat alcoholism that's been repurposed to treat Lyme. And how we got into this was there was a researcher named Dr. Rojadas out in Stanford University that found in laboratory experiments that disulfiram has the ability to treat persister Lyme. And in that initial experiment, he did not do any studies to look at whether it treated growing Lyme or not. Subsequent studies have shown it probably treats growing Lyme, but it's not that effective against growing Lyme. Okay. Disulfiram, probably based on further research, has some ability to treat Babesia, but it's a weak agent against Babesia. And disulfiram has no effectiveness against Bartonella at all. And there's been subsequent research done out of Hopkins that showed it's not an effective agent. And many of us that have worked with it don't find it to be an effective agent, okay? In my practice, I will use disulfiram these days if I've got somebody I treated adequately for all forms of the germ, Lyme germ, and I treated them adequately for persisters, and they didn't get better, then I might consider doing disulfiram. But there's some problems with disulfiram, so I kind of use it as a drug of later resort, okay? So what we know about disulfiram, this is based on some published case studies by Dr. Liegner looking at 70 patients he had on disulfiram, but also based on my own experience, which kind of matches what he found. So it appears to be able to get about 36% of people into extended remission, maybe get the germ totally out. Okay, so it helped about 30 to 35% of people get there. Okay, however, about 40% of people have to stop the drug due to side effects. Okay, so it's a harsh drug to take. That's the problem. The other problem with, in terms of side effects, I'll go through those with you in a minute, but there is, and a lot of people that use disulfiram, they get neuropathy. And for most people, that nerve injury, which can lead to nerve pain and numbness, will go away when you stop the medication. But I have found in my practice a very small percent of people that have been left with permanent nerve injury and permanent severe nerve pain. So it's a very small percentage of people, but you have to be aware of that when you use it, okay? All right, so in terms of side effects of disulfiram, the most common one is about 50 to 60% of people when they're on it will get fatigue, okay? About 30% of people while they're on it are gonna have some form of psychiatric problems, sometimes resulting in hospitalization, psychiatric hospitalization, like bad hallucinations, severe depression. And about 15% of people will get neuropathy of some kind, of which the majority of that 15% will get better once you stop the medication, okay? Now, when you use the medication, it's gonna take a couple months to get up, maybe 2 to 4 months to get up to a full dose. And then once you get to the full dose, you have to stay on it for another 4 months. During that time, you have to restrict your diet quite a bit so that you're not taking foods that look like alcohol. All right, so no alcohol, no tinctures that have alcohol in them. And then there's a whole other group of foods that you just have to avoid when you're on it. So it's a difficult drug to take, basically, all right? So yeah, it's something to consider, but I would consider it as a later resort. I would first want to make sure you maximize other treatments, that there was an adequate treatment for Lyme to begin with, as I mentioned earlier, and that Babesia wasn't missed here, and that there's not mold toxicity. If there was inadequate treatment of Lyme, if all forms of the germ weren't dealt with at the same time, and if persisters were not dealt with at the same time, I would look at other ways of going after that first before I take the risk of doing disulfiram. Okay, all right. Let me just do a quick screen share here for you. And obviously, I mean, I'm not your wife's physician. These are things you should be talking with your physician about as well, too. Okay. All right. Let me just do a screen share here. Okay, so in terms of the disulfiram, all right, so the article that I have is called Disulfiram for Lyme Disease. And I just actually updated it today, by the way. And what the update is I made it, it is now the same as the article, the chapter I have in my book called Hacking Lyme Disease: An Action Guide to Wellness, is a compilation of about 40 articles from this site. And the disulfiram article I have here now is updated to be identical to what is in the book, okay? But anyhow, if you go through here, you're going to see in terms of treatment outcomes, as I said, about 36.4% get into permanent enduring remission. About 50% have some kind of fatigue with it. About 30% have psychiatric issues, 15% neuropathy, and 50% can't even reach the target dose due to side effects, okay? And then I describe when you might want to consider using it. I talk about you want to make sure there is not intestinal yeast overgrowth when you use it. I talk about how do you start it, how do you dose it based upon a person's body weight, and I go through supplements that may make it easier to tolerate it while you're on it. I list the foods to avoid here, and then in terms of if you want to find other ways to treat persisters, I have a whole different article on that called How to Treat Persister Lyme and Bartonella. And through here, I walk you through a number of options that you would use rather than using disulfiram, okay? All right. Heather, good luck to you. Good luck to your wife. Hello, Valerie. What happens when phosphatidylcholine gets taken with antibiotics and supplements? My adult child Lyme patient got a wave of brain fog and did this for many months. His symptoms got worse. Can this be the cause? So phosphatidylcholine, everyone, is known as a phospholipid. It is one of the phospholipids that is used to make up a cell membrane, and is found in, it also is one of the phospholipids that is used to make up your mitochondria, your cell energy factory membranes as well too. Another big one that makes up nerve cell membranes in the brain is something called phosphatidylserine. But you could use these phospholipids to help rebuild the coverings of your nerves and even the mitochondria as well too. I have never seen in my working with phosphatidylcholine, and where I work with it it's a component found in a product called ATP 360, which rebuilds the covering on your mitochondria and therefore can rebuild the covering on mitochondria. It also would be found in something called NT factor as well too. I have not seen anyone get brain fog that got worse by being on it, okay? But again, I would caution you of a statement I made earlier tonight, which is, in my experience, anything can happen to anyone with anything. And while I don't think that this is a common side effect, could be a side effect in your son, all right? So I would just stay away from it. Sometimes the things that are not common can happen. And so we need to avoid those things that trigger it. Okay. All right. Thanks for a question, Valerie, and good luck to you and good luck to your son. Oops. I think we answered this one earlier, Arena. Hello, Denise. Hello, Dr. Ross. Thank you for all you I'm new to Lyme. Should I take the Igenix immunoblot first? And if positive, what do I check for specific positive co-infections? Thank you. All right. So these days, I think the best initial test to do to see if you have a Lyme infection first is to do the immunoblot from Igenix. So what an immunoblot is, it's a test technique that Igenix has come up with that looks to see, has your immune system made antibodies against 8 different kinds of Lyme germs, okay? There's no other lab out there that is testing to see if you have a reaction against 8 different kinds of Lyme germs, all right? So it makes it much more sensitive. Its ability to find Lyme is around 90 to 95% if Lyme is present, all right? The other thing that they do in this test that makes it a good test is they remove the possibility of false positives due to chronic virus infections, creating antibodies that happen to attach to the Lyme germ. And the way they do that is they take the proteins from these 8 strains of Lyme germs, and they genetically produce them in the lab, cleaned up of pieces that might hold on to antibodies from viruses. So they're clean, all right? So you tend not to get false positive tests too, okay? It's in that test using the immunoblot, you want to check for IgM and IgG antibody immunoblot is going to be 450 US. Where I usually will start with patients when I think Lyme is present and I think they might have co-infections is I'll start with that first. If it comes back positive, then I often make my decisions about whether I'm going to treat for co-infections based on what the symptoms tell me. All right. So if somebody has enough symptoms of Bartonella, I'm going to treat them for Bartonella. And if somebody has enough symptoms of Babesia, I'm going to treat them for Babesia. The reason I don't necessarily test for those is if I have a strong clinical suspicion that they have Bartonella or Babesia, even if the testing came back negative, I would still treat them. And the reason is Bartonella testing is going to miss it. Even Igenix testing is going to miss it about 10% of the time. Babesia, you're probably going to miss it about 10 to 15% of the time as well too. So I go on what my clinical suspicion is. Earlier tonight, I showed you an article called How to Diagnose Bartonella, where I review what Bartonella symptoms are. If you have a lot of those, then you probably have Bartonella, okay? And there's a similar article about how to diagnose Babesia. You would take a look at that and the symptoms in there. And if you have a lot of symptoms of Babesia, then my practice has always been treat based on the symptoms, okay? If, however, you're a person that wants to get testing that confirms that, be aware if you have the symptoms and the testing isn't confirming it, that doesn't mean you don't have the infection. It just means the testing didn't pick it up. The lab that I would use, though, to test for Bartonella and that I would use to treat for or test for Babesia would be Igenix. And again, I would use their immunoblot method, and so the reason I would use their immunoblot method is in their immunoblot for Babesia, they test for 2 or 3 strains of Babesia and in addition to the whole family. All right. So if the family test comes back positive, but the specific strains for Babesia microti and Babesia decani, so the 2 strains actually, are negative, that means you've got one of the other strains that is not decani and not microti, basically. Okay. And a big one might be something called Babesia oticoli. All right. All right. Right. And same with the Bartonella. The Bartonella, we recognize that there's about 15 strains that can infect humans. The Igenix Bartonella immunoblot can look to see if you have antibodies against 4 of those specific strains. And in addition, it can tell if you have antibodies against the whole family. And that family has 15 members, again, that can infect people. So it's a better test for that reason too. All right. Good luck to you, Denise. Thanks for your question. Cheryl, I see that you've tried asking me your question a number of times. The trouble is you're making it, unfortunately for this platform, it's too long of a question. I don't think it's showing me the whole question, so I still don't have something to answer here. All right. Hello, Ken. My doctor has me on doxycycline 250 milligrams times 1 times 2 daily, and also on Septinir 300 milligram times 2 daily. I was not seeing very good results and was so run down that I took an additional dose of the defense for 2 days, and the response was remarkable. I find it hard to believe that I seen such a change. However, I went back to the prescribed dosage and felt the results negative within the next 2 days. Let's see. Ken, I'm not sure how to respond here because you said you took an additional dose of the defense. I wonder if you mean the doxycycline. And I'm not clear how you're using 250 milligrams of doxycycline, because doxycycline comes as a 100 milligram pill. You could be taking 2 of those for 200 milligrams, or I guess you could be cutting in half and doing 250 milligrams, but I'm unclear about what the dosing is here. I can't comment on this. All right. Sorry about that. Hello, Pat. Hi, Dr. Ross. If you needed to prove to a doubter that chronic Lyme does exist, which facts and data would you provide to them? Thank you for these insightful webinars. Boy, that's a hard one. You might. So there's a book written by Brian Fallon. He's a medical doctor at Columbia University, runs the Columbia University Lyme Center. He's a psychiatrist, and he's kind of in the middle of the road. He doesn't believe that chronic ongoing antibiotics work, but he also acknowledges that chronic Lyme can exist. Okay. And so he does a fairly good job in his book. It's called Crossing the Divide, I believe. Here, we'll look it up together here. He does a good job of laying out the argument that there is something called chronic Lyme. He does diverge from the rest of us in the Lyme world, and that he thinks that years of antibiotics is not appropriate. He does think, though, that months or more could be appropriate. But as I remember reading his book, I think he does a good job of laying out the argument for chronic Lyme disease. Let me see if I can find his book here. I'm going to do a quick screen share. Let's see here. Conquering Divide, I think it is. Here it is. It's called Conquering Lyme Disease, Science Bridges the Great Divide. Okay, so it's an in-between book, but I think he does a good job laying out the argument that there could be something called chronic Lyme in here. Okay. Thanks for the question, Pat. Good luck to you. Hello, Sally. Let's see. Can you speak more about methylene blue, pros and cons for those with Lyme disease? So methylene blue is a drug that is made to treat a condition called methemoglobinemia that has been repurposed to treat Lyme and Bartonella. I'll just start by saying that, okay? So what it's designed to do, there's a condition that some people have called methemoglobinemia, where their hemoglobin which is in the middle of your red blood cells. Hemoglobin binds oxygen and helps carry it through the body inside the red blood cells. There are some people under stress states where when they're under stress, either physical or medical stress, they get into crisis where their hemoglobin does not release the oxygen. That's called methemoglobinemia. And so methylene blue is designed to be given in an IV form, and it effectively bumps the oxygen off of that hemoglobin so that they can oxygenate their tissues, basically. It has been shown in laboratory experiments to also be effective at treating growing and persister forms of Lyme disease. Okay, not in human experiments, but in laboratory experiments. We know that in an oral form, the pharmacist will tell us and have data that show in an oral form, it's very well absorbed out of the intestines and crosses over across the blood, what's known as the blood-brain barrier. So therefore, it can get into the brain quite effectively as well too, okay? The dosing that I usually like to use when I'm using it to treat persisters, I like dosing it to start with at 50 milligrams twice a day. And sometimes I will go up to 100 milligrams twice a day. I believe Horowitz, Dr. Richard Horowitz, sometimes goes even higher than that in some of his treatments as well too. There are people though that advocate going a lower dose, 25 milligrams twice a day. All right. The things that you need to do as a safety precaution before you use it, there's a couple of safety issues to think about. Number one, you need to make sure that you have adequate levels of an antioxidant in your blood called glucose 6-phosphate dehydrogenase, or an enzyme called glucose 6-phosphate dehydrogenase. And so you get a G6PD blood test, all right? If you do not have adequate levels of G6PD, it can result in hemolysis, rupture of your red blood cells if you take a methylene blue. So you want to get that blood test done first, okay? Number two, it can lead to some elevation of a chemical in your brain called serotonin. And if you happen to be on other things that raise serotonin, like the antidepressant medicine, the SSRIs, the SNRIs, so your Cymbaltas, your Prozacs, your Zolofts, your maybe even Effexors, if you're on things that you're taking for depression that can raise serotonin, then taking it with methylene blue could be a problem, because you could get into something called serotonergic syndrome where you get too much serotonin, okay? Now, I have used it with antidepressant medicines, but you want to make sure that my patients are not taking high doses. They're more on low to moderate doses, all right? But some physicians won't do it. The trouble is we don't have good science that tells us how much is too much methylene blue to take with antidepressant medicines, but it's a theoretical concern, okay? The other problem I have seen with methylene blue before is there's an occasional person that it actually irritates the lining of the bladder and will give them a lot of urinary frequency and urinary irritation. The other side effect I've seen people get a lot of intestinal cramping on it in the past before too. And then finally, the biggest side effect is it turns everything blue. When you pee, you're going to be peeing out blue. When you poop, you're going to be pooping out blue. And in your toilet, it becomes very difficult to clean it off. I've had people that just spend forever scrubbing it off the toilet. So the stuff, right? And then finally, the other side effect is it's expensive. So you're talking somewhere in the upper $300 for a 1 month supply of it. Here in the States, the two places that I will get it from are either a lab called PD Lab, a compounding pharmacy called PD Lab in Cedar Park, Texas, just outside of Austin here. And then the other lab that place that you can get it is InfuServe, which is out of St. Petersburg, Florida. Hopkinton Pharmacy in Massachusetts used to do it, but they sold their business, their compounding business, to PD Labs. Okay. All right. And so those tend to be the places you can get the pharmaceutical grade. Okay. And then in terms of using it, I like using it as part of my Bartonella treatments when I've got somebody that has a lot of brain fog that's not lifting. Again, I like using it as my agent to treat persisters. So for Bartonella, I might combine it with like azithromycin, 500 milligrams a day, along with methylene blue, 50 milligrams twice a day. That could be a full Bartonella treatment. And people with that have brain fog that's really stuck, I might add diflucan into that as well, to 200 milligrams a day. In terms of Lyme, you could do like a clarithromycin, azithromycin, doxy, or minocycline along with it. But I would also, and those would pick up intracellular and spirochete Lyme, but you'd still need to be on something also to treat cyst growing Lyme. And for that, I would probably use grapefruit seed extract, 250 milligrams twice a day, and then use methylene blue as my agent to treat persisters. Okay. Anyhow, there you go. Those are just some brief overviews on the methylene blue. All right. All right. Thanks for our questions, Helen. Oh, another reason to use methylene blue is if you're on dapsone to treat persisters, that can sometimes give you methemoglobinemia. And so in that case, you can use methylene blue to reverse that as well too. Okay. It's interesting, Dr. Richard Horowitz has his dapsone protocol, which he uses to treat for persisters. In re-looking and thinking about some of his data about whether it could work or not work, the one thing that's interesting is he likes combining it to prevent the methemoglobinemia from developing. He uses a lot of methylene blue with it. And maybe his data suggesting that dapsone works may be skewed by the fact that a lot of those patients are using methylene blue. I'll just throw that one out. Okay. All right. All right, everyone. All right. That's it for me for tonight. I've been here with you for about an hour and a half. I think I heard Thor just come in here a few minutes ago, but it looks like he's not going to be. Hey, Thor. Thor. Hey, Thor. I thought he might show himself tonight, but it doesn't look like he's going to. Anyhow, I've enjoyed being with you here tonight. Keep a lookout in your email tomorrow morning, somewhere around 9 to 9:30 a.m. Central Standard Time in Austin, Texas here. I will have an email put together and get that out to you. And in that, we'll have information, a synopsis of what we talked about in the webinar, as well as a link where you can listen to it. And in addition, it'll have the ability for you to sign up for next week's webinar as well, too. When you get that, help me reach more people. I'd appreciate if you would share that with email with as many people as you think might get benefit. All right. All right. Good night, everyone. And I wish you well. I'm glad we were all together again tonight, too, after having to take a couple weeks off.